During this lecture, I'm going to cover the main clinical problems that present during early pregnancy and the ultrasound features that are found. I'm going to describe them in detail to enable the clinician to use ultrasound as a combination to their clinical skills to accurately diagnose in early pregnancy. So what is the importance of scanning in early pregnancy? The problems that affect this stage of pregnancy are essentially miscarriages, which affect 20 to 25% of pregnancies according to how you define a miscarriage. Ectopic pregnancy, which affects 1 to 2% of pregnancies, and the rarer problem of molar pregnancies affecting 0.1%. Ectopic pregnancy is clearly a life-threatening condition. In the UK and America, it has a mortality rate of 0.08%. In Africa, a mortality rate of 27%. So what are the relevant points? As well as looking for pathology, we need to establish the normal features of the pregnancy. Is the pregnancy intrauterine? Is the pregnancy a viable pregnancy? Is there any evidence of bleeding or hematoma? Is the uterus on scanning empty? If so, has an ectopic pregnancy been excluded? If there are retained products of conception after a miscarriage, how much and where? So starting with normal findings, characterising the normal ultrasound features on scan. Depending on whether you're using a transvaginal probe or a transabdominal probe, obviously a transvaginal probe will give you greater resolution and enable you to see the early pregnancy much earlier. We first see a gestation sac, at 4 to 4.6 weeks of gestation. That is accurately dated from the first day of the last menstrual period, corresponding to 32 to 34 days. At this stage, the gestation sac is 2 to 4 millimeters in size. This cannot be seen by transabdominal scan. By transabdominal scan, we first see the gestation sac at 5 weeks gestation, at which point it is usually around 10 millimeters in size. The gestation sac is characteristically positioned eccentrically, in other words, towards the outside, within the thickened decidua. Okay, the other feature in normal early pregnancy is the embryo. This can first be seen at 5 to 6 weeks and is characteristically 4 to 8 millimeters in size. By 8 weeks of gestation, the crown rump length is 14 to 20 millimeters, and you can see in this slide the calipers placed accurately from the crown to the rump. Also alongside you can see the yolk sac, which should not be confused in scanning and included in the measurement of the crown rump length. Moving your probe to clearly separate the appearances of the yolk sac from the embryo itself will help you avoid this error. By 9 weeks, more features of the early pregnancy can be discriminated. By this stage, we have a more fully formed embryo with clearly defined poles of head and rump. We can see membranes, the innermost amniotic membrane, the outermost chorionic membrane. In between the two is the exocoelomic space, and lying in that space, visible until approximately 12 weeks, is the secondary yolk sac, visualised quite separately in this slide from the embryo, as opposed to the earlier 8-week appearances. The crown rump length at this stage is around 22 to 30 millimeters. In the second slide, you can see again, clearly demonstrated, the amnion, the chorion, the exocoelomic space, and the amniotic cavity lying around the embryo and bounded by the amniotic membrane. Having described the normal features of early pregnancy, let's now go on to another very important purpose of early pregnancy scanning, which is dating. Dating the pregnancy is one of the most important factors in antenatal care, and the accuracy of dating, both in taking a history and on scanning, is very important to perfect. As you know, clinically we data scan from the first day of the last menstrual period. So earlier scans are most accurate for dating. When using transvaginal scanning, classically this is done at between 5 and 6 weeks of gestation. With transabdominal scanning, it necessitates a slightly more advanced pregnancy to get the views that are good enough to achieve dating. So classically this is done between 7 and 13 weeks. The features that we look for in performing a dating scan are the gestation sac and its size, the presence of a yolk sac and its size, and the measurement of the crown rump length. What do we see at this dating scan? As we've said earlier, we see the head, we see the body, we'll see a heartbeat, we'll see the placenta and the yolk sac, amniotic fluid, we'll see the cervix, we'll see the limbs, we see the presence or absence of twins and multiple pregnancies, and we also survey for adnexal masses. Before proceeding, we should just be clear about the terminology. As in the literature and when discussing early pregnancies with colleagues, it's very important to have a uniform terminology. So when we look at the early pregnancy scan, we talk about the gestational sac diameter. This is a measurement taken in two planes. In the longitudinal plane, there are two measurements, and in the transverse plane, there is a third measurement. These three diameter measurements help to define a volume. We also refer to the crown rump length. This refers to the measurement of the embryo from the tip of the head to the tip of the rump or bottom. And as explained earlier, it's terribly important not to include the yolk sac within this measurement. Looking at multiple pregnancies on scan in early pregnancy is really important. This gives us an opportunity to establish chorionicity. The factor of relevance here is that a monochorionic pregnancy is a pregnancy associated with much more adverse outcome and risk. So using this opportunity to accurately determine the chorionicity is very helpful for clinical reasons. In this slide you can see what's referred to as the twin peak sign, or the lambda sign, because of it resembling the Greek letter lambda. This shows a triangular projection of placental tissue from the chorionic surface, or twin peak, leading into a membrane dividing the two pregnancies on this slide. In a dichorionic pregnancy, the membrane is characteristically thicker, classically described as being more than 2 millimeters in thickness, and coming out or evaginating from this triangular process. Seeing this twin peak sign is very diagnostic of dichorionic pregnancy. Its absence, however, does not exclude it. Now we'll talk about some clinical scenarios and the use of early pregnancy scanning in those scenarios to help us diagnose and manage the patient. So if we consider the scenario of bleeding in the first trimester, this is a common presenting problem and must be taken very seriously. In the first instance, we've all been taught that any bleeding in the first trimester must be considered an ectopic pregnancy until proven otherwise. This is determined largely by the potential adverse outcome with an undiagnosed ectopic pregnancy. Collapse of a patient, bleeding volumes into its abdomen is not desirable. Diagnosing an ectopic early enough to prevent this adverse outcome is obviously terribly important. So how do we go about this? Well, first of all, we must understand the differential diagnosis of this problem. Bleeding in the first trimester, although considered an ectopic until proven otherwise, could also represent a miscarriage. We'll go into the classifications of different types of miscarriage. It could be an ectopic pregnancy, or it could be a molar pregnancy. Let's just dwell on the point of miscarriage and its definitions. In the literature, you'll see many terms used in association with miscarriage. A lot of them are now obsolete, confusing, and for the purposes of universal communication, it's very important to use just a small number of fixed terms. So, when talking about miscarriages, we talk about complete and incomplete miscarriages. This relates to a clinical diagnosis, may be backed up by ultrasound, in that the pregnancy was viable, has been expelled, has bled, all of the products of the pregnancy have been expelled, and the miscarriage is therefore termed as complete. Conversely, in the scenario where the miscarriage has happened, the fetus is no longer viable, the bleeding has commenced, tissues of conception have been expelled, but on ultrasound we can still see evidence of retained tissues. This is described as an incomplete miscarriage. We also have the terms missed miscarriage. This is now frequently referred to as an early pregnancy failure. A missed miscarriage describes the scenario where an embryo dies early fetal demise. However, the pregnancy and its tissues and fluids and gestation sac are not expelled, they're retained within the uterine cavity. This is commonly diagnosed on ultrasound when a gestation sac is seen with or without a fetal pole within it, and the pregnancy is no longer ongoing. A threatened miscarriage, again, is frequently a clinical diagnosis backed up by ultrasound findings. A threatened miscarriage represents the situation where a pregnant lady with a positive pregnancy test is admitted to hospital complaining of bleeding, and we scan the pregnancy and find that there is a heartbeat, the embryo is still alive. However, there may be a large hematoma, classically a subchorionic hematoma, and we may feel that the pregnancy, although at that moment in time ongoing, is threatened. So now we're going to take a further look into clinical presentations and symptoms. So we're going to just discuss a few of the scenarios that will commonly present at any hospital and to any doctor dealing with early pregnancy problems. So if we consider a scenario where the last menstrual period was more than 5 weeks ago, the pregnancy test is positive, the lady is presenting with vaginal bleeding, and she has lower pelvic pain. This is the classical scenario where we are considering all the conditions that we have referred to earlier in this lecture. So now we're just going to speak briefly about how we're going to clinically diagnose this scenario of early PV bleeding, pervaginal bleeding. Okay, so it's a combination of taking a careful history, dating the pregnancy accurately from the first day of the last menstrual period, correcting for cycle length. In a lady who has a prolonged cycle, perhaps she has a 6-week cycle or a 5-week cycle, one must remember that the fixed phase of the cycle is the luteal phase, the post-ovulatory phase, the last 2 weeks of her cycle. Let's just speak a little about clinical examination, scan findings, and blood analysis to enable us to make this diagnosis. So firstly, clinical examination will always start by observation of the patient, moving on to taking her pulse, examining her abdomen, and then finally performing the vaginal examination. In the scenario of a collapsed patient who has experienced an ectopic pregnancy, this is very straightforward. The classical signs of shock will be present of pallor, sweating, tachycardia, rapid pulse, a rigid abdomen with rebound and guarding. In many cases, an ectopic pregnancy may present without having ruptured, and we hope this is the case. We will be evaluating the patient who has an ectopic, but it has not yet bled or ruptured, and therefore all of the acute symptoms and signs that I've described will not be present. In this instance, gentle examination of the abdomen may find slight guarding or tenderness to one side. Moving on to the vaginal examination performed digitally, then careful examination of the cervix by positioning the 2 examining fingers either side of the cervix and moving the cervix gently from left to right would elicit a lot of pain in the patient with an ectopic pregnancy. This sign is described as cervical excitation. Then proceeding to examining the adnexy, the area either side of the uterus, digitally and placing the abdominal hand in the corresponding position over the adnexa being examined vaginally, one may feel a lump or mass which would correspond to the ectopic itself, or may simply elicit marked tenderness, which is much more on one side than the other. Finally, on digital examination, the size of the uterus is very relevant. So having accurately dated your pregnancy clinically, palpating the uterus between your vaginal hand and abdominal hand will give you an impression of size. If the size is appearing to be much smaller than the gestational age, this might alert the examiner to the presence of an ectopic pregnancy. Okay, we'll then move on to the use of the speculum. The speculum is very useful in discriminating between the types of miscarriage. So, having prepared the speculum by warming it and lubricating it, the speculum is gently introduced to visualize the cervix. In the event that the cervix is tightly closed, then one can reassure the woman the miscarriage is simply threatened. Of course, an ectopic pregnancy will present also with a closed cervix. In the event that the cervix is found to be open, then one can proceed to discriminate between the different types of ongoing miscarriage. So one may even see the expelled conception itself in the vagina with placental tissue, decidual tissue. This would be an inevitable miscarriage. One couldn't discriminate whether it was complete or incomplete without performing a scan, but a large quantity of blood and pregnancy matter in the vagina would certainly alert us to an inevitable and perhaps almost complete miscarriage. So then moving on to the ultrasound scan, as I described in my earlier slides, having very carefully evaluated the case clinically by taking a history and by examining, we now have a very sharp focus on the differential diagnosis that we are hoping to clarify by ultrasound. Finally, the use of HCG in diagnosing ectopics and miscarriages is something I'm going to describe. This is a very useful adjunct to diagnosis where one has the facility of measuring HCG levels. HCG is a hormone that is produced uniquely by trophoblastic tissue. It forms the basis of the pregnancy test. Its levels, however, are also very useful in diagnosis in early pregnancy, since its levels rise exponentially, characteristically doubling every 48 hours. In a normal, ongoing, viable pregnancy, the exponential rise of HCG, the doubling over 48 hours, is a very strong indicator of the well-being of the pregnancy. In an ectopic pregnancy, one will see a continued rise of HCG. However, because the implantation process is very limited by the site of implantation, which is ectopic and is not supporting a good placental formation, the HCG levels, although rising, do not double over the 48-hour period. We refer to this as a suboptimal rise. In a failing pregnancy, an inevitable miscarriage, the HCG levels will be seen to fall. So one can see that this is a very useful parameter in evaluating early pregnancy. It brings me to another point, which is that in the evaluation of early pregnancy, it's very important to take several views at the case and not to come to any firm conclusions on a single clinical visit, because it's also the evolution of symptoms, signs and ultrasound findings and blood parameters over time that will lead one to an accurate diagnosis. Okay, now we're going to look in more detail at the ultrasound findings in miscarriage. I make no apologies for the repetition. So we will be going over some of the material that I've already covered. So how do we how do we define a miscarriage? A miscarriage is defined as the spontaneous loss of a pregnancy before viability, which in the UK is defined as 24 weeks of gestation. So what are the definitions in early pregnancy failure? In the literature, as I've described before, we see terms like blighted ovum, missed miscarriage. I would urge you not to use these terms and to simply refer to early fetal demise or early pregnancy failure. I will just describe the features so that we all understand what we're referring to here. As I've established earlier, a missed miscarriage is a miscarriage where there has been early fetal demise. The fetal heartbeat is no longer visible, is no longer beating. This has been checked over 2 separate occasions to ensure that there is not an error, a discrepancy in dating to account for the absence of a fetal heartbeat. So once we are quite certain that the absence of a fetal heartbeat is truly representative, then we also measure the gestational sac diameter. If the gestational sac diameter is more than 20 millimeters in its longest diameter, there is a secondary yolk sac, and there may or may not be an embryo visible. There is an embryo of more than 6 millimeters in size with no fetal heartbeat, then we can diagnose a missed miscarriage. So just to recap and clarify, the embryo must be more than 6 millimeters in length to ensure that the absence of the fetal heartbeat is not purely related to an early gestational age. The gestational sac must be more than 20 millimeters in diameter, again to exclude the possibility of an early pregnancy that is simply not advanced enough for us to see a heartbeat. The presence of a secondary yolk sac and an embryo also are very helpful but not essential in making this diagnosis. The old term blighted ovum refers to the finding of a gestational sac which is empty. There is no embryo. The sac is retained. It has not started to break down and be expelled, but there is no embryo within it. This represents a very early fetal demise, and perhaps the early embryonic tissue has been broken down and is no longer visible on scan. I would like to emphasize that one must always check these findings at least 1 week apart, 7 days apart, to ensure that one is not, in fact, misinterpreting an early pregnancy. So here are some other findings that one may see on scan in early pregnancy demise or missed miscarriage. One can visualize the failing pregnancy in various stages of breakdown. So in this first slide we can see a small or disrupted hematoma, which is the ectopore area surrounding the gestational sac. We can see an irregularly shaped gestational sac, which is very indicative of a failing pregnancy. Sometimes we see no embryo or yolk sac in a gestational sac of more than 20 millimeters in diameter. This is strongly suggestive of early fetal demise. On occasion we see no embryo, but we see a very large yolk sac, as shown in this slide. And in the situation where an embryo is visible, the absence of a heartbeat in an embryo measuring more than 5 millimeters is also strongly indicative of early fetal demise or missed miscarriage. The measurement of gestational sac size is a very useful feature of examination of the early pregnancy. Gestational sac sizes in the first trimester of pregnancy are something that is quite reliable and correlates very well with gestational age. There are charts that will give you a normal range for sac sizes. With great experience, one becomes able to simply scan a pregnancy and have an impression of a small sac relative to gestational age. I want to just dwell on the finding of a small sac. It's often a very useful indicator of anomaly of the pregnancy. It is often the way that aneuploid or chromosomally abnormal pregnancies can first be suspected, as they classically present with a very small gestational sac. The finding of a small gestation sac can also lead one to suspicion of a threatened miscarriage, since often small sac size and absence of progression in growth, which is classically 1 millimetre a day, can be indicative of a pregnancy that's no longer thriving. Okay, so let's just dwell a little on threatened miscarriage. Threatened miscarriage is defined as vaginal bleeding presenting in the presence of a live intrauterine pregnancy. In this slide, we can see the difference between a threatened and an inevitable miscarriage. In a threatened miscarriage, the pregnancy is viable. There is some bleeding. Classically, it comes from the margin of the placenta, maybe just from the placental edge. In an inevitable miscarriage, you can see the bleeding behind the placental tissue, significant subchorionic hematoma being expelled through an open cervical os. Okay, so threatened miscarriage, one will see pain and bleeding with a closed cervix, and on scan one sees a fetal heartbeat. A very common finding in this scenario is the presence of a subchorionic hematoma. These hematomas are very well tolerated, and one can see really very significant subchorionic bleeds without the pregnancy eventually becoming compromised. So their finding is an indication for close observation and serial scanning, but is not necessarily a predictor of outcome. Okay, so returning to ectopic pregnancy, we've spoken at quite some length already about ectopic pregnancy. Ectopic pregnancy can be a life-threatening gynecological emergency. So in the UK, 1 out of every 250 ectopic pregnancies results in death. This is obviously a reducing figure with improved early diagnosis. The rate of ectopic pregnancies in the UK, however, is something that is still significantly high. 1 to 2% of pregnancies are ectopic. This is related to the frequency of pelvic infection, which I've referred to earlier. Okay, so ectopic pregnancy, as we've said, presents with lower abdominal pain, with or without bleeding. 90% of ectopics can be diagnosed by transvaginal scan, as compared to only 50% by transabdominal scan. The term ectopic pregnancy refers to an aberrant location of pregnancy at implantation. So as you can see in this slide, there are many locations for an ectopic pregnancy. Classically, it's tubal in the fallopian tube. It could be at any point along the fallopian tube. It can be isthmic, which is at the junction of the uterine cavity and the fallopian tube. It can be infundibular, which is right next to the tubal fimbria at the ovarian end. The ectopic pregnancy can implant in the ovary itself. It can be an abdominal ectopic location, so outside the uterus and tubes altogether, and it can be cervical. All of these locations can potentially be diagnosed on transvaginal scan, some with great difficulty. So where the ectopic pregnancy can be clearly seen in the fallopian tube, we can see on this slide nicely demonstrated image of a gestation sac and an embryo lying between the uterine cavity and the left ovary. It's quite difficult to visualize an ectopic pregnancy like this, and frequently ectopic pregnancies are actually diagnosed by exclusion on finding an empty uterine sac at an advanced gestation, without having the actual positive finding of the ectopic pregnancy itself. Finally, molar pregnancies are important, mainly because in the presence of complete mole there is an association with invasive gestational trophoblastic disease. So molar pregnancies are rare. They can be complete or partial. Complete moles are diploid, entirely paternal in their genetic makeup, very much more commonly associated with progression onto gestational trophoblastic disease. Partial mole is triploid in genetic makeup, so there is an extra paternal genetic component. In both instances, the abnormality is of excessive trophoblastic growth. The genetic component from the male is thought to largely control the development of trophoblastic and placental tissue. The female genetic component influences the development of the embryo. In complete mole, the findings on ultrasound are of a uterine cavity completely filled and overcome by uterine vesicles. These are areas of trophoblastic tissue that have become fluid-filled and have completely overtaken the uterine cavity. We describe these findings as a classical snowstorm appearance. Okay, so on this slide we can see the classical snowstorm appearance with the uterine cavity filled with cystic trophoblastic material. In 30% of cases, theca lutein cysts can be seen on the ovary, and there is no fetus. This is a typical characteristic finding in complete mole and enables the examiner to differentiate it from partial mole, where a fetus may be present, and so to remind one that it is complete mole that is associated with the potential progression to invasive disease. Of clinical relevance also is the fact that when these pregnancies need to be evacuated surgically, the risk of bleeding is very high, and therefore one should take precautions to anticipate this, since complete moles bleed very, very heavily. This last image gives us another view of the snowstorm appearance within the uterine cavity. So in summary, accurate evaluation of early pregnancy features on scan, understanding the key pathologies at this stage in pregnancy, and careful clinical examination, using ultrasound as an accurate adjunct to assessment will really improve your patient care in early pregnancy.